Hi, everybody. We are getting ready to begin our live broadcast, another episode of our Science of Sleep Apnea live broadcast series. I see a couple of you have already joined us. If you are joining us as we speak, please go ahead and introduce yourself in the comments section of the chat box and make sure that you grant StreamYard permission to use your name so I know where you're joining us from. I welcome each and every one of you. This is going to be an exciting broadcast, and I want to give you time to settle in and register your name and just get comfortable with the whole virtual broadcast that we are going to bring to you over the next hour. So as you are logging in, please go ahead and tell me who you are and where you're joining from. My chat box is empty. I'm waiting to hear from you, friends. I see there's a number of you that are watching already, but I need to know who's with me and what your names are and what area. Are you joining us from Canada or the United States? I would appreciate, and it's important because the conversation is really what makes these broadcasts rich in learning. So as you are settling in, I want to remind you that we are embarking next week. Oh, hello, Jason Medor from Newfoundland. Thank you so much for saying hello. Hi, everybody. It's so great to be back with you. Dr. Tammarie Heit and I took a break over the summer and thought now that we're back into the swing of things, it's fall, it's time to resume our virtual series in the science of sleep apnea. This is episode number 7 already. Welcoming all of you who are joining us right now. Jason said hello from Newfoundland. I see there's a number of you watching. Please go ahead and introduce yourself and let us know where you're joining us from. Winston Wing, hello from Peace River, Alberta. Says, hello, everybody. Thank you for logging in tonight. Who else is with us and from what area? Winston, looks like you're watching on YouTube tonight. Chuck Korveg. Hi, he says, hi, Carrie from Edmonton. Hello to you, Chuck. Appreciate the time that you're going to spend with us this evening for this conversation. I was going to say we're embarking on a really exciting week in the science of sleep apnea. Tammarie Heit, Dr. Tammarie Heit and I are headed to Las Vegas next week for a huge conference. On Wednesday, we're going to be bringing you another installment of our Science of Sleep Apnea series with talking about the AHI Conundrum. That's on Wednesday, October the 20th. And then on Thursday, October 21st, we will be bringing you Dr. Sahil Chopra, who is a speech specialist and intensive care doctor. He's going to be talking about telemedicine. So this is a huge conference that is taking place in the United States. And it's if you would like more information, the website is thevivosinstitute.com. And we'll be coming to you live from there with a number of different guests. Welcoming all of you who are watching tonight. Please go ahead, like I said, and introduce yourselves so I know where you're joining us from, what your area of medicine and specialty is, so that Dr. Heit and the rest of the people that are on this virtual broadcast, Dr. Morong, can learn from you, can interact with you, and chances are they know you, so don't hesitate. I'm going to begin shortly, but I can see there are still more of you that are logging in. And please make sure to grant StreamYard permission to use your name. Otherwise, you're going to show up as a Facebook user. But if you give StreamYard permission, it's at the top of your screen. That way I can know who I'm talking to. So once again, scienceofsleepapnea.com is where you can see all of our previous broadcasts if you're interested in watching them. And then our conference next week is the website is thevivosinstitute.com. All of you joining us tonight are much too quiet. Well, there's someone else, Marty Frankel, joining us from Toronto tonight. I can see Dr. Heit smiling as she's watching in the virtual green room. She must know you, Marty. Maybe a connection to Dr. Morong. Ryan Rudy joining us from I'm not sure where, but says hello, Carrie. And I say hello back to you, Ryan. So as all of you are logging in and getting settled in, I want to welcome you and continue to introduce yourselves. So Ryan, you're joining us from Edmonton because as I hear your questions, Dr. John Caulfield, is it from Colorado? Is that where you're joining us from? Epic Dentistry. Is that a thumbs up, Tammarie? Is it from Colorado? She's giving me the thumbs up. Welcome to you, Dr. John. It's great to have you with us as well. I love it when you join in the conversation. We welcome your questions. Don't hesitate to do it in real time. I'm getting a thumbs up from Epic Dentistry. Thank you to all of you who are sharing your time with us tonight. So on that note, in the interest of time, we have so much to get through. I want to begin by saying that this is another important conversation about sleep apnea as we zero in and explore the impact of different treatment options and how experts can best counsel patients on those options, the risks of those options, and of course, the benefits of each choice. We will be joined momentarily by two leading experts in this field. And this is a very important conversation as we talk about forging relationships between medicine and dentistry in the treatment of sleep apnea. So on that note, let me say hello and welcome to each and every one of you, doctors, dentists, researchers, scientists, and friends joining us from all across North America. Welcome to this live broadcast, The Science of Sleep Apnea, collaboration between medicine and dentistry and the impact on the prognosis of treatment using diagnostic sleep endoscopy. So what exactly does it mean? How does it work? And how can it impact lives? We are going to dig into all of those questions tonight. As I mentioned a little bit earlier, this is the 7th broadcast we are bringing you in our Science of Sleep Apnea series. All of the conversations to date have been insightful discussions and have brought together so many experts from across North America in all kinds of medical and dental fields. If you're interested in watching any of the conversations to date, you can find them on the website, thescienceofsleepapnea.com. And now I can see a lot better. You can also watch this broadcast there as well. If you hear something tonight, you think, wow, that was blockbuster. And you're going to hear a lot of blockbuster information tonight. And you're like, I need to share this with someone. I need to go back and listen to that again and absorb it. That's where you can find all of the broadcasts that we have done to date. And you know what's really interesting? So far in this series, we have interviewed, get this, cardiologist, a neurologist, a sleep specialist for both adults and pediatrics, a medical doctor, and an internal medicine specialist. And tonight we are adding on an otolaryngology head and neck surgeon. So how exciting is that to bring together all these experts from so many different areas of medicine and dentistry. Brenda is now with us from Edmonton. Brenda, welcome to you. It's always nice to have you a part of our broadcasts. I should take a moment and introduce myself. It's Carrie Dahl. I was a longtime television medical reporter turned 6 o'clock news anchor for many, many years. And now I'm a public speaking coach and a podcast host. And I'm so honored to continue to serve as your host for tonight's virtual events and all the other ones we've done to date and will continue to do. We, of course, appreciate all the time that you are taking out of your lives to listen and participate in tonight's broadcast and learn more about the incredible work that is being done in diagnosing and reversing sleep apnea. Yes, I did say reversing sleep apnea because it's happening, and we'll talk about that tonight. As I mentioned, we want to make this evening as informative and as interactive as possible. So please, I encourage you to join in on this conversation. As you can see, I will read questions and comments as they come in. You do not need to wait until the end of the broadcast. If there's something you want to ask of either expert while they're talking, I will work it into the conversation. All you have to do is simply type your question in the comments box. And I mentioned too, to make sure that you grant StreamYard, which is the technology that we're using tonight, permission to use your name so I can actually read out who is asking the question and from where. So the format for the next 60 minutes will look something something like this, I will begin by interviewing dentist Dr. Tammarie Heit, who is the driving force behind these broadcasts. And she really is on a mission to increase collaboration between dentists and doctors in diagnosing and treating sleep apnea. Dr. Heit is based out of Edmonton, Alberta, Canada. She will discuss her research, the novel approach that she uses, and her incredible research results. And on that note, I want to say hello to Sahil Chopra joining us from California, USA. On that note, Sahil will be joining us live from Las Vegas next Thursday. And we're actually doing that particular broadcast in front of a live audience, plus live here on the internet. So please, please, please make sure to mark your calendars for that. It's happening at 4:30 Pacific time, 5:30 Mountain Standard Time. Mark your calendars. That's going to be such an insightful conversation on telemedicine. And Sahil will be talking further about that. And he is a renowned expert in his area of expertise as well. So we can look forward to that. Hello to Nadine Crooks joining us from High Prairie, Alberta. We appreciate the time. Okay, following my interview tonight with Dr. Heit, we are going to bring in Dr. Sharon Morong, who is an ENT surgeon and board certified sleep specialist from Toronto, Canada. She's going to explain what diagnostic sleep endoscopy is and how it can benefit patients. And then I'm going to bring back Dr. Heit to join Dr. Morong. Two of them can join in some conversations. I know that Dr. Heit has a few questions about diagnostic sleep apnea, what it is, how it works. And so the two of them can discuss that further. You're also going to see a very interesting video on what the throat actually looks like and how it closes up in a patient that has sleep apnea. I can see Dr. Morong smiling in the virtual green room right now as she listens to this. She's looking forward to that conversation. So certainly a lot to cover tonight, but research and work in this area is changing lives. And as I mentioned, throughout the next hour, we welcome your questions. Jason says it's 9 p.m. Newfoundland time, and Rita Peugeot is joining us from Toronto. I hope I said that name correctly, but welcome to you if you were watching. Okay. Oh, we're going to wrap up our night. I should tell you that too, because I know that you all have busy lives at 6:30 Mountain Standard Time. And again, if you want to rewatch this broadcast or share it with any of your colleagues or friends, it will live on the website, thescienceofsleepapnea.com. As I mentioned, for all of you joining us tonight, if you want to watch the upcoming episodes next week when we are live from Las Vegas, we are attending the Breathing Wellness Conference in Vegas, and you can check out that website, thevivosinstitute.com. So with all of that, let's dig in, shall we? By welcoming Dr. Tammarie Heit, who, as I mentioned, is the driving force behind these broadcasts and so determined and passionate about fostering more collaboration between doctors and dentists and diagnosing sleep apnea and ultimately saving lives. Dr. Heit has spent the last 25 years in general and craniofacial dentistry and lecturing worldwide for 10 years to dentists, orthodontists, and medical doctors on her published research and her findings. Dr. Heit has successfully reversed sleep apnea, which she will talk about. She is also on a relentless mission to get dentists and doctors to work together on the diagnosis and treatment of sleep apnea. And without further ado, I bring into our broadcast the one and only, the amazing Dr. Tammarie Heit.
Hi.
Hello there.
Hi, everybody. Thanks for joining tonight. I'm so excited to be here. And Carrie said I've successfully reversed sleep apnea, which is true, but many of you watching this have also done it. And there's lots of dentists successfully reversing sleep apnea. So I'm just so thrilled and excited to show you what's going on tonight.
Okay, Dr. Heit, tell me why you wanted to dig into this topic tonight.
Well, I came up with this topic. There was a presentation by our guest today, Dr. Morong. It was on the Canadian Academy for Dental Sleep. She might have to help me with that one because I had it on a slide with the website on it. Right. But I watched her presentation, and dentists are looking at the anatomy of the jaws and the teeth. And, that's what we see. We see teeth, and we're excited about the anatomy, and we can see changes in the anatomy with our treatment, but we're starting to look at sort of medical issues and relating it to those changes in the anatomy. So this patient here is an example of someone who we were able to grow her upper jaw with a dental device, and a removable dental device, and get rid of her headaches. But we realized that then there was enough room for all her upper teeth, and we could tell maybe the upper jaw is too small. Now there's room for the upper teeth, and the bottom jaw was now able to come forward. So in essence, we started to think about the airway, because part of the upper jaw, has a nasal airway. So when we increased the size of the upper jaw, the nasal airway also increased. And then when the bottom jaw was able to come forward, because we could round the teeth out, then the airway in the neck opened up. So this person's pain may have gone away because we helped the airway and with sleep apnea. So in this person, I didn't do a sleep study before and after treatment, but basically why I'm excited today is we're looking at this anatomy on the outside, and Dr. Morong is looking at the anatomy on the inside. So that's why I'm excited, and why I want to speak with you today. And I think her lecture was April 14th of 2021. And I'm going to tell you at the end of this which website you can go watch that lecture on, because it was phenomenal. That's what motivated me to do this today.
Dr. Heit, I just want to introduce Anwar Manji, I believe. He's from Pakistan. He says this is a good topic today. Thank you. I love watching, is what he says. So we have our viewers as far away from Pakistan. Welcome to you, Anwar. We appreciate the fact that you're joining us tonight. Okay.
Great.
Dr. Heit, let's talk about the non-surgical approach that you are doing with this removable dental device.
That's what I explained on this one. So we can, basically grow the upper jaw with this removable dental device. And it's lots of dentists on this call are doing it. We want medical doctors to know that we're doing it, and we want them to know what effects we're getting. And that's what we're trying to communicate here. And I think that's going to come about when we start communicating in the same language, and they see what it is we're doing, and we see what it is they're interested in. And it's about communication. I think that's going to come through research and getting results. So this collaboration between medicine and dentistry is absolutely huge, and it's going to make this very successful, which is then going to help a lot of people. So that's what I'm really excited about.
Help comes in a variety of different ways when using this device, but can you talk a bit more about the impact on headaches? That's a big one for so many patients, and how do you go about measuring that?
So I simply use, and again, I got this from a neurologist that I worked with. We actually did a little study together. We measured blood flow in the brain and how it changed with a dental bite, and we published that too together. And the way he measures it, in a way a lot of medical doctors measure it, is with the HIT score, which is a headache impact test. And if you Google HIT 6, you'll be able to find this questionnaire. It's like 6 questions. So if someone scores 78 on that questionnaire, that means they've got the worst headaches ever, constant severe headaches, which completely impacts their life. If they score 36, that means they don't have any headaches. So that would be the goal, is to not have any headaches ever. And 50 is kind of the clinical cutoff point. Anybody who scores 50 and above is kind of clinically significant. So when we started measuring headaches using this, these were my results, and the headaches were all coming down. And so we're starting to measure that now as we're working with our medical colleagues to see what is important to them. And then we can start putting all this research together. And I know there's more than 20,000 patients in treatment now by dentists in the United States and Canada, and even around the world, doing this technique. So very, very excited about the impact, not only on sleep apnea, but headaches.
And the impact can be huge. And I think one of the things that interests so many dentists, doctors, and really patients is that this dental device can work to change anatomy. And even when I've shared that, a lot of people are like, wait, how does this work?
Well, this is, here's an inside view, kind of what I think about when I see my patients. The upper jaw you see there is called the maxilla. And when it's big enough, it can hold 16 teeth. And even in this image here, the wisdom teeth are missing. It's just so common to take out wisdom teeth now that we don't even think of it as abnormal. But in essence, this image here is abnormal in the sense that the upper jaw isn't even big enough to hold the wisdom teeth. So ideally, we're genetically predisposed to have 32 fully erupted teeth, 16 on the top jaw and 16 on the bottom jaw, and they shouldn't be crooked. So if we're able to grow the bone volume of the upper jaw, not only does the arch grow big enough so the teeth can be straight, but the hole in that bone, the nasal airway also grows. And so any resistance in that area that leads to upper airway resistance can be resolved. And then naturally, when that bone is big enough, then the bottom jaw, the teeth can fit with that. It can come forward then into a nice arch and open up the airway in the neck. And that's essentially changing the anatomy of the upper airway in two spots, both in the nasal airway and in the neck part of the airway. And what I'm thrilled to see is, like, I'm constantly looking at cone beam CTs and looking at bones and teeth. And Dr. Morong is going to look at all the soft tissue inside of there. So looking forward to that.
So with all of those changes in anatomy that you've just alluded to, how does this tie in and impact sleep apnea?
So, we can't always just take an x-ray every time we want to test for sleep apnea. So we use an AHI score, and that's apnea hypopnea index. So basically, I'm going to show you a patient here who had one of these apnea hypopnea indexes of 118, which is literally 4 times severe. So medical doctors will look at AHI, apnea hypopnea index, ODI, oxygen desaturation index, or RDI, respiratory disturbance index. And, they vary, those values vary. So the take-home message for dentists is just use the same machine before and after on that patient that you're testing, so we can compare apples to apples. So in this particular patient, it was AHI, and we took the tonsils out and her AHI went down to 70, but that's still more than double severe. So what I see as a dentist is jaws and teeth. And so when I'm looking at her with an AHI of 118, and I'm looking at her teeth and jaws, if I think of her teeth and jaws like a garage and the tongue is like a car, when the AHI is really high, her bottom jaw is too far back, meaning she has a garage for a smart car. And her bite is deep, meaning the upper teeth in the front there are overlapping her bottom teeth by at least 50% there. So her garage has a 5-foot ceiling. So after the treatment, when the jaw came forward, there was more room for the tongue, which is the car. And from the front view, you can see it was a 1-car garage, and now it's a 2-car garage. So what this did is result in the clinical reversal of sleep apnea just by having enough room for the car in the garage. And of course, medical doctors know that when a person loses weight, their tongue loses weight, and the sleep apnea values also drop. But think of the dentist, because we can affect the garage. Now, one of the problems is the diagnosing of sleep apnea. And our next episode is going to be with 2 experts on the conundrum of AHI. So don't miss that. Dentists should watch that too. But even medical doctors are a little nervous about, diagnosing it and really, seeing the impact. But really, if we compare apples to apples, look at things before and after, and relate them to each other, this is where medicine and dentistry can collaborate to really reverse this condition.
So we can clearly see, and you talked about like the changes in the teeth and the jaw and whatnot, but you can also see these effects on the face, can you not? And that first picture you showed us, there was a dramatic change in that woman's face.
Yeah, and like the first patient, this patient here, I didn't know if they had sleep apnea before and after treatment. This is the same treatment. I used a boat therapy, a biomimetic oral appliance therapy, but it was, again, for pain. So this guy had pain, and in fact, one of the condyles in his jaw was just gone. And the surgeon just said, you kind of have to live like that. because surgical intervention in the jaw joints, it's the risks outweigh the benefits many times. But we were able to completely reverse his pain. And then because I took this photograph, it's a submental vertex photograph, you can see the improvement in the symmetry of the functional space of the nares there. And they just look larger and more symmetrical. And you can see this, and people say that they're breathing through their nose for the first time. And so you can see these changes, and patients can feel them. And now we can measure them by looking at cone beam CT as well.
You can see the changes, but the key is how are they measured for diagnosis of sleep apnea by medical doctors, because that is where it can get a little bit confusing and challenging, and where everybody needs to communicate, correct?
Yeah, that's true. So this is just a group of my patients in kind of snapshot in time, and all the patients pre-treatment had sleep apnea. And you can see the dark blue area is the severe sleep apnea, and as it gets lighter, it gets to the more mild. And then post treatment, normal is the very light blue on the group of blocks on the right. And so lots of that sleep apnea was reversed, and some of the severes have shrunk right down. But some of those severes, they started in this case an RDI, of 97, and they end up at 32. Well, 32 is still severe, so it's still going to be in that category, but it doesn't mean it didn't have a great big clinical impact. So what I'm excited about is just showing you this anatomy and these craniofacial features, relating it to something measurable that contributes to the diagnosis of a deadly disease called obstructive sleep apnea. Mm-hmm. And now I'm excited to see what Dr. Morong is going to show you, with what she sees as an ENT, looking inside at the soft tissue, and how do we link those together?
I love that you say you're excited to see what she's going to say, because really, and I want you just to speak briefly about this before I introduce Dr. Morong. Just talk about, because you have been doing this for so long, Dr. Heit, how important collaboration is between dentists and doctors.
Yeah, I just feel like we're going to save a lot of money in our healthcare system by prevention. And if we can kind of communicate or speak the same language, if I maybe a medical doctor doesn't think cone beam CT is as sexy as a dentist does. Maybe they like the sleep endoscopy better. And but if we can relate those two things together, then we'll be speaking the same language. Because if they can see the results we're getting and maybe measure our results using their technique, we're speaking the same language. We can not only reverse sleep apnea in people, but also prevent it. And I think it's really important to save money for our healthcare system, because there's so many terrible downstream effects from people who have obstructive sleep apnea. Mm-hmm.
And it's a massive impact for them and for our healthcare system, like on their lives. But the work you're doing is having, speaking of impact, huge impact. And as you alluded to, showing us the pictures in patients. And I can't wait for you and Sharon to talk a little bit later. So on that note, I'm going to allow you to catch your breath, because I know you have questions for her, right?
Yeah.
Many questions. Okay. I'm going to let you catch your breath for a while and relax in our virtual green room. Dr. Heit, thank you very much. We'll see you momentarily. And then on that note, it's now my pleasure to introduce our special guest tonight, Dr. Sharon Morong. As I mentioned earlier in our broadcast, Dr. Morong is an otolaryngology head and neck surgeon certified by the Royal College of Physicians and Surgeons of Canada, subspecializing in sleep medicine and sleep diagnostics. She is also a lecturer in the Department of Otolaryngology, Head and Neck Surgery at the University of Toronto. During her career, she has received numerous awards, has published multiple peer-reviewed articles and book chapters on sleep medicine and sleep surgery, and has spoken on national and international platforms about drug-induced sleep endoscopy. She is now the director of the Sleep Endoscopy Center for Snoring and Sleep Apnea in Canada. Before I say hello to her, I want to welcome Sanjeev Jain. He says hello from Toronto. And Epic Dentistry says amen to Dr. Heit's presentation. They apparently all enjoyed that. So on that note, joining us from Toronto, Ontario, Canada, let's join me in welcoming Dr. Sharon Morong. It is so nice to have you here with us, Dr. Morong.
Hello, it's so nice to be here. This is great.
So let's dig in, shall we? I know time is of the essence, and let's just begin by explaining it for anyone who may not understand what it is. What is drug-induced sleep endoscopy, and why is it used?
Sure. So firstly, thank you so much for having me here. It's such a pleasure to be a part of this collaborative series. So thank you.
Our
And
pleasure.
to answer your question, when we think about the process of diagnosing and treating a patient with sleep apnea, we think about a patient who's presenting to their healthcare provider with symptoms of snoring, poor sleep, daytime fatigue. And that patient is typically assessed, and then it's followed up with a sleep study. Now, if that patient is diagnosed with obstructive sleep apnea, the sleep study has served its purpose. It served its purpose in informing and diagnosing the patient with what they have. The problem there is that at that point, neither the healthcare provider nor the patient actually has an understanding of why they have sleep apnea. And that often leads to generalized recommendations for CPAP because CPAP is very effective. The problem is there are a lot of patients who are not able to tolerate it, right? So that's where sleep endoscopy comes in. Sleep endoscopy is a technique that's used to answer the question, why do I have sleep apnea? And it does this by identifying the different anatomic locations that may be causing obstruction in a patient with sleep apnea. And then with that information, you can come up with a more comprehensive treatment plan or treatment options for the patient to enable them to make a more informed decision.
Okay, so that answers the question of why, but now let's move into how. How does it work, Dr. Morong?
Yes. So a patient is typically placed under sedation, right? Just to the point where they're snoring. And then the airway is visualized with a black flexible scope that you see here on the diagram. The scope is inserted through the nose. It's advanced towards the back of the nose, and then it's curved down. So you get this bird's eye view of the airway. And the inspected anatomic sites that we look at are circled in red here. If we start at the top, you have the uvula and the soft palate. Then you have the tonsils or the lateral walls of the airway. That's followed by the base of the tongue or the back of the tongue and the epiglottis. So at all of these sites, 3 questions are asked. 1, is there an obstruction? 2, what is the type of obstruction you're dealing with? And 3, how severe is the obstruction? So if we see obstruction at the level of the tongue base or the epiglottis, then what we do is we simulate what an oral appliance or a mandibular advancement device would do. We gently advance the jaw to see if the airway would open up or if we're able to reverse the vibrations of snoring that occur. So we have a video here. And this video is going to be a sleep endoscopy video of a patient who does not snore and who does not have sleep apnea. So looking at this video here, you can see that bird's eye view that I was talking about, looking down towards the airway. If you look at the bottom of the circle here, the bottom of the circle represents the front of the airway, and the top of the circle represents the back of the airway. And if you look straight down, if you look at the anatomy going from the bottom coming up, you have the vocal cords. Just above that is the epiglottis. Above that, you have the base of the tongue. Just on the right, you'll see a tonsil protruding into the airway. And above that, you have the back of the uvula or the soft palate. But the most evident thing here is that the airway is wide open, totally unobstructed.
So that is nice and clear. It's wide open, but you also have a really interesting video as well.
Yes.
Of what it looks like for someone who has sleep apnea. I alluded to this because my jaw was on the ground. And I was like, oh my gosh.
So if we have the other slide, there's a slide that shows a collection of different patterns of obstruction. I'm not sure if this isn't the slide. We have another one. And if we can find that slide. So this isn't the slide here. And it just shows different types. If we don't have that, that video, that's okay.
We're working on getting you that slide there, but is this the video?
No, that's not the video. We have the suspense. We're waiting in
As we
anticipation.
try to dig it up, let's talk about what we're seeing with the obstruction and when in a patient that has sleep apnea.
So what the video will show are different types of obstruction, right? And there are different types in terms of the configuration or the shape of the obstruction. You have anterior-posterior palate obstruction, where the palate is going back and forth. You have, at the same level of the palate, something called concentric palate obstruction, where it closes in like a sphincter. And then at different levels, you have obstruction at the tongue base, obstruction at the epiglottis. So it's okay if we don't have that slide, because this one is a perfect case that shows two of those obstructions. And before we play the video, I'll just let you know a bit more about the case, right? So this was a patient who pretty much presented to their sleep physician with poor sleep, because they were having these sudden violent gasping episodes, and they were diagnosed with obstructive sleep apnea, and eventually they were prescribed a CPAP. Now, unfortunately, with the CPAP, even at higher pressures, they weren't able to control their sleep apnea. And the interesting part about that was that their gasping episodes actually got worse when they were using the CPAP. So this patient came to me for a sleep endoscopy, and if we play this video, we'll see what his endoscopy looked like. So here, looking down, the first level of obstruction you see here is the level of the palate. So here, this patient has an antero-posterior palate obstruction, because the palate is moving back and forth to obstruct the airway. As we go further down, the second level of obstruction seen here is the epiglottis. This is the trapdoor phenomenon. Every time he breathes in, his epiglottis blocks his airway. So what I do here is I simulate an oral appliance. I bring his jaw forward to see if it opens up the airway. And you can see here, his airway opens up, and the epiglottis is no longer obstructing his airway. So at this point, with the jaw still advanced, I slowly pull the camera back up, and you'll see the epiglottis is no longer obstructing, but unfortunately, his palate is still obstructing. So the treatment options I presented to this patient were, one, to have combined palate and epiglottic surgery, or have a combination where he would wear an oral appliance to resolve the epiglottic obstruction and get palate surgery, or he could continue with his CPAP and use it with an oral appliance. Now, he was not keen on surgery at all, so he decided to continue with his CPAP with the oral appliance, and we were able to get his pressures down to a level that was comfortable for him, control his sleep apnea, and the gasping episodes were gone. So that was great.
Dr. Morong, I have a question here from Sanjiv Jain, and it says, when you sedate the patient, is there a state of sleep you are trying to achieve, as sleep apnea presents differently in different stages?
Okay, so great question. So when we're doing, I guess from that question, the question that comes up is pretty much, does the sedation mimic sleep? And the answer is no, it does not. There have been studies that have shown that patients with propofol on board, they have way more deep stage 3 sleep, and there's no REM sleep there. But what we do see in those studies is that there is no difference in the respiratory obstruction, and there's no difference in the AHI. And what we're looking for here is just the levels of obstruction that the patient has. When it comes to the state of sleep, there are two ways of assessing the state of sleep. One is a clinical assessment. So clinical assessment would be basically they are not responsive to verbal stimuli, their eyelash reflex is inhibited, but they can respond to pain. Now, there is a way more accurate way of doing it, which is using EEG parameters, using a bispectral index monitoring system. But unfortunately, that's very expensive, not much access. So we base it on our clinical assessment when we reach that state where the patient is snoring.
Thank you very much for addressing that. Hopefully that answered your question. And if you have any further comments, please chime in. We welcome them. Okay, Dr. Morong, let's talk about what you find to be some of your most challenging cases to treat.
Okay, so my most challenging cases are patients who have what we call a concentric palate obstruction. And you'll see it in this video here. So if we can play this video, you will see that the concentric obstruction is one where it closes like a sphincter, right? So looking at the palate very closely, you see here, right? It's closing in like a sphincter. And this type of concentric palate obstruction is the most challenging because these are the types of patients that don't fully respond to oral appliance therapy. They do not do well with palate surgery or soft tissue surgery, even with newer surgical innovations like hypoglossal nerve stimulation, where you implant a device in the chest that stimulates the hypoglossal nerve to protrude the tongue as the patient breathes in. Any patient that's actually interested in a device like that, according to the FDA regulations, they must have sleep endoscopy done first. And if on sleep endoscopy, it's found that they have this type of obstruction, concentric, unfortunately, the patient is no longer eligible for treatment. So their options are really limited. It really comes down to either trying CPAP, which they have done already, or, they're trying to now pursue maxillomandibular advancement surgery, which is pretty invasive. This is what excites me about bone therapy, because this is a therapy that has the potential to actually increase the volume of the airway in patients like this, right? And do so in a manner that's not invasive. So I see this therapy as really promising.
That's exciting because Dr. Heit spoke about that and the ability to increase the volume of the nasal passage. So you agree with that? This is a therapy that you would like to see used in these types of situations.
Yes, and you brought up a good point there about the increase in the volume of the nasal passage. Because from the ENT, otolaryngology perspective, we see patients who come in all the time with problems with nasal obstruction, restricted airflow. And what we tend to do is we tend to focus on the structures within the nose. So we look to see, is the septum straight or deviated? Are the tissues in the nose, the turbinates, are they swollen? Are there polyps, sinusitis? And we tend to, forget or overlook the actual foundation of the nose, which is the floor of the nose, the lower half of the lateral walls, which is the maxilla, right? So what can happen in a patient who has a deficient maxilla is that we do surgery goes well, but then that patient still cannot breathe well. They're still restricted. And they end up, unfortunately, going from ENT surgeon to ENT surgeon, getting multiple surgeries with no improvement, simply because we didn't look at the maxilla. So if anything, just hearing those findings about the improvement in the volume of the nasal passage, it should hopefully increase awareness for us as otolaryngologists to know that when we examine the nose, we should examine for maxillary deficiency too, so that we can actually counsel our patients to say, you know what, nasal surgery may help, but with a deficient maxilla, the success may be limited if the maxilla isn't addressed as well. So I'm glad you brought that up. I wanted to bring that in.
Well, and on that note too, it opens the door to the question of how important, I know this is your area of expertise, but let's talk about how important you think that sleep endoscopy is to medicine, and ultimately how important is it to patient outcomes?
Yes. I think, Carrie, that the future of sleep medicine, sleep health, sleep wellness, it really depends on collaboration across all specialties, dentistry, medicine, surgery. And, the beauty of a collaboration is knowing that while you may have one patient that responds really well to one treatment, there are other patients who need more than one treatment modality to achieve that same success, right? And that is what collaboration is about. And I think that sleep endoscopy is a really powerful tool to be able to help facilitate that collaboration. And ultimately, that will lead to improved patient outcomes.
We're hearing that word over and over and over again, the
Yes.
power of collaboration. Before I bring Dr. Heit back in, I think we have some patients who are watching tonight. Ryan Rudy wants to know, do you need a referral to see Dr. Morong?
So you can contact my office through the website directly, and then we will basically do an assessment.
Okay, so that's how it works. And we can give, you have your website. We can give that out a little bit later after
Sure.
we're done our conversation. Okay, Dr. Morong, so insightful. I especially love the videos that you shared with us so that we can actually see what you're
Yes.
seeing and we don't have to
Yes.
visualize it in our mind. But speaking of collaboration, let's bring back Dr. Heit into this conversation because I know that she has a ton of questions that she would like to ask you tonight. So, Dr. Heit, I could see you just like, all right, you have a few. So I'm going to go ahead and let you take the lead on this.
Well, I love looking at the outside anatomy, and it's funny because you said maybe ENT should start looking at maxillary deficiency, but it's really pretty easy. Just look, if their teeth are crooked, then their maxilla is deficient.
Mhm.
So
Something we don't do.
yeah, and another interesting thing when you were talking about the floor of the nose was many of my patients who we use this device on, it has acrylic across the palate. We custom make this device to their presenting anatomy, and as the patient develops, and with boat therapy, which is really important, sort of more generic word I want to refer to the DNA as, is biomimetic oral appliance therapy, because it changes the spatial relations of the jaw and allows the body to develop around it. And then a person has to adjust the device to the new phenotype. So what happens is the patient will come back a month later and that acrylic is actually touching their palate. And we take an acrylic burr and we cut the acrylic off the palate. And every time I do it, I take it out of the patient's mouth. I said, you're doing a great job wearing this 12 to 16 hours a day. The roof of your mouth is the floor of your nose, and we're dropping that. And that's why I like cone beam CT. And I see the changes in a patient's face, in their presentation. They feel better. They say they're breathing through their nose. Their headaches are going away. Their HIT scores are going down. We can measure the bone volume of the maxilla using cone beam CT, and just relating those hard tissues. And not all ENTs, I think, are that jazzed on the cone beam CT for diagnostic purposes. But what I was wondering is, as far as research goes, how would we relate the value of the prognosis of diagnostic sleep endoscopy with kind of the hard tissue, the hard tissues we see change in the cone beam CT? Like, can we relate those two things?
And that's the challenge there, right? But I think at the same time, that's where the collaboration needs to happen, because with the cone beam CT, we're looking at it's a static image and the patient's awake, but you get the quantitative measurements. With sleep endoscopy, you're getting that dynamic real-time collapse, but we don't have a way of measuring quantitatively, right? So I think it would be having sleep endoscopy where you can actually see where the collapse is happening and being able to correlate that with the images on CBCT at that level. And either we measure the AP distance, or we decide if we're going to measure the circumference, but at least it gives you two pieces of the puzzle that will come together for us to get a better picture of if there is progress and how much progress is happening with treatment.
Well, that's fantastic. So if there's other ENTs watching this and other dentists who have cone beam CTs, you guys get together. The other thing you talked about, the concentric palate obstruction, and those poor patients, they kind of don't have a choice. They almost need MMA, which is just cash registering both jaws surgically forward by the oral surgeon, maybe in collaboration with ENT. But what about the ability to grow the maxilla with a removable dental device in a non-surgical way? Is that potentially an option for this patient? And should those patients try it? Because the only other option is kind of do nothing or do this horrendous, well, not horrendous, but big surgery.
Yeah. But that's exactly it. The video I showed here, there are much worse, where pretty much I refer to it as a pinpoint airway. And there are other factors too, in terms of weight. A lot of the tissues around is adipose fatty tissue that weight loss has to be a part of the management. But in general, you can lose weight, but if the bony structure is deficient, those tissues cannot tense up, open up, right? So you need that bony expansion to happen so that those soft tissues are no longer draping over and collapsing on each other. So to be able to actually grow the maxilla, that's exactly what these patients need, because there is no surgery other than jaw surgery that would be able to fix, an anatomy like that.
And I feel like dentists have been growing maxillas for decades, like all different ways. We've come up with like so many different appliances to grow it, but now we need to measure some of these functional issues that happen around our soft tissue changes and sort of determine exactly which direction, like, is it omnidirectionally? Do we lose AP or gain width? Everybody wants to expand the arches. Patients just want straight teeth. So dentists will take teeth out to make them fit. And that's been done for a long time. And, there's lots of records on that. That's like an acceptable treatment in dentistry, but dentists are starting to think past that now. And the ability to grow the maxilla is a game changer, because we were taught in dental school that the maxilla could not be grown in adults, yet it's been shown it can grow by 1.8 cubic centimeters,
which is amazing. Amazing.
Ladies, I want to bring in this question and comment from Dr. Jane. It says, I had a patient with high CPAP pressure requirements, a slim middle-aged woman. It didn't make sense. So I requested ENT consult, and patient had make sure I'm saying this right, a nasopharyngeal. ENT assessment was invaluable. Thoughts on that?
Yeah, and the nasopharyngeal carcinomas, they are located at the back of the nose, right? And that's where our scope comes in, to be able to see into these tiny holes that, other people can't see, and discover things like this. So that's why we do have to work together. Dr. Jane is a sleep physician, and without having that open-mindedness to reach out to an ENT, ultimately because of that, the patient did well from a serious health perspective, apnea and a carcinoma that was found. So that's great.
So I want to ask this question from, I'm not the medical expert, but looking at this from the outside in to both of you, why is collaboration so difficult and so challenging? Dr. Morong, okay, Dr. Heit, you go for it.
We need to speak the same language. Dentists tend to look at teeth and talk about teeth and hard tissues, and ENTs talk about their thing. But I think we're each building a puzzle in our own little corner. Now it's time to link up our puzzles to get the full picture. So I recognizing what each other does, so that we can do research together. As an example, I was able to get rid of a neurologist's migraine headaches with a piece of plastic and so that led to us going into the stroke lab and putting on the middle, checking the blood flow of the middle cerebral arteries, the thing that they do for stroke patients, and with the device in the mouth and without it in the mouth, and there was an increased blood flow in the brain with the device in, and it's kind of like, how does that happen? Why does that happen? And I think just sort of we got to start a multi-center study on headaches and all this stuff together, and I think it's worthwhile looking at some of these clinical trials and things, and I think that's happening now in vivos with the development of the medical consortium, and it's going to be very, very powerful. Oh yeah, thank you. There's what I was looking for at the beginning. So Carrie, you asked me at the beginning of the presentation what made me want to do this.
Yes.
I saw Dr. Morong's presentation on this and at the Canadian Academy of Clinical Sleep Disorders Disciplines, or cacsdd.org. So if you guys go and watch this, you're going to love it. But it's called Collaboration is an Essential Component of Precision Medicine. And that's what this is. It's precision medicine. And dentistry's a part of it. And this is really exciting. So this is a great group that people can go on and, join and watch some of these webinars.
Dr. Morong, you want to weigh in with your thoughts on collaboration? I know you did already in your webinar, but for
Yes.
everybody who didn't have a chance to see it or listen to it, why don't you comment on why this is so important?
So, collaboration is so important because it's an understanding that in each of our own silos, we don't know everything. And that is why collaboration has been a bit difficult, because you have medicine and we learn our language of medicine, and you have dentistry and you learn your language of dentistry. And because we don't know the language of dentistry, instead of reaching out to learn about it, or we ignore it or overlook it or dismiss it, right? And I think it has to start at the educational level. In the medical schools, in the dental schools, have physicians come in to give lectures. I believe Dr. Jane does that already. But I have never been taught by a dentist in medical school. I would have learned so much. So, starting at that level, I think will help to foster that collaborative culture for us to be able to move forward and be more open-minded to collaborations like this, which is really important.
Dr. Heit, wouldn't that be fabulous to go into
Yeah.
medical schools and have dentists and doctors like lecturing to one another about their individual specialties? Like, that would be a massive step forward at the very beginning of training, would it not?
Yeah, absolutely. And that's why I think doing research together, kind of linking up that sleep endoscopy with the cone beam CT, that'll give us the kind of result that can be taught and used in dental and medical schools, demonstrating a collaborative effort. And so the people graduating actually have some exposure to it, and the people out there can also learn. So I think it would be powerful.
Yes.
Dr. Morong, I appreciate your time so much. I know everybody watching as well, and your expertise, the thoughts that you've led to this conversation. Kristen Weaver just weighed in and she said that would be amazing. I agree as well, to have both sides communicating. I know that you're all are so busy, and we appreciate the time and the efforts that you're taking to build bridges and to use Dr. Heit's analogy to put the pieces of the puzzle together, bringing in all these different pieces. And your area of medicine and specialty is an important one, Dr. Morong. So I really appreciate the time that you gave us tonight and the conversation. Lisa Babiak says, thank you very much. And we had up your information there. It's Dr. Sharon Morong, Sleep Endoscopy Center for Snoring and Sleep Apnea. I guess people can Google you, or your website is sleependoscopy.ca. So for those of you looking to get in touch with Dr. Morong, that is how you do it. Just head to her website and you can find out more information there. Dr. Morong, thank you so much for joining us.
Thank you. This was great.
We appreciate you so much. On that note, Dr. Heit, I'm going to keep you with us because we have a little bit of time here at the end, and I have a few details to go through. But I just want you to talk about what's happening next week in Vegas, because we're headed there for a massive conference.
Yes, that's going to be really exciting. The Breathing Wellness Conference put on by Vivos Therapeutics. I think they're the leaders in this, and it's sold out, it's oversold, and it's going to be at Caesar's Palace. And these webinars we're doing, we're actually, we're going together, and we're going to do 2 of these webinars next week, one on Wednesday and one on Thursday. So the Wednesday night one is going to be about the AHI Conundrum. So, how does the AHI from one sleep device translate to another sleep devices? And what's the difference between all these take-home sleep monitors? And what if you have one that you've had for years and you want to get the new technology? How do you translate it if you already have a patient in treatment? Things like that. And then on Thursday night is going to be telemedicine. So that patient that was looking for a referral there with Dr. Morong, wow, I think you're going to be able to do it no matter where you are. I think telemedicine is completely possible in this. So this kind of diagnosis and treatment is going to be available to anybody, no matter where they are. And Dr. Sahil Chopra is an intensive care unit specialist from California, and he's leading this, and he's amazing. And I can't wait. It's going to be phenomenal, especially, I mean, it's one thing sitting here in front of the computer doing this, and it's going to be quite another doing it live from Caesar's Palace, the Augustus Room. And we'll still have the virtual audience too. So
Yes.
if all you on this show want to watch us do our first one of those and maybe fall on our face or something.
No, that's not going to happen. So for those of you wondering how that's going to work, we're going to have a huge conference room filled with, let's hope, 500 people watching us on stage, but we're also going to be broadcasting to the virtual world at the same time. So this is really exciting. We're going to have experts in the field that are in the room and virtually around the world. So mark your calendars for both broadcasts. Wednesday night, Thursday night, 4:30 Pacific time, 5:30 Mountain Standard Time. Insightful conversations as Dr. Heit continues to put the pieces of this puzzle together. We have Kristen Weaver saying, awesome upcoming topics. Can't wait. Thank you very much, Kristen's. And the Isabella's family, I will be in attendance with you in Las Vegas. Can't wait.
Yes.
And I look forward to meeting you. So please come and say hello to me as well. I will be in tow with Dr. Heit. Winston Wing says, fantastic presentation today. Yes, yes to collaboration. Thanks for always being an inspiration.
Well, it's my pleasure. Winston is such a phenomenal doctor and dentist, and he's a leader in this. So yeah, it's great to have you on here, Winston.
I'm looking forward to spending a few days with you, Dr. Heit, and with so many other experts in the sleep area and learning more and hearing more. So once again, those broadcasts are next Wednesday, October the 20th, Thursday, October 21st, all coming to 4:30 Pacific, 5:30 Mountain Time. And I really, truly hope that you can join us. In the meantime, if you want to share this broadcast and conversation with any of your friends and family, or you want to rewatch it, all you have to do is go to the website, thescienceofsleepapnea.com. So with that, Tammarie, I thought I'd just keep you on to the very end. And we can say, oh, and there, the last word we're going to give to Dr. Chopra. He says, great conversation. Thanks for putting this together. Looking forward to seeing you all in Vegas. Dr. Chopra, I look forward to seeing you as well and meeting you and doing the live interview on stage. And Stas Pavlenko says, great presentation. Thank you all for the hard work and spreading the message. Thanks. Closing thoughts, Dr. Heit?
Everybody on here, you're just part of the breathing wellness movement. If you go to the vivosinstitute.com, there's more upcoming events, even though this one is sold out. Just get to them all and just keep going and keep leading, because as you know, it's not a hard treatment for dentists to do. And you're a student and a teacher at the same time, because you're going to get the results. And then people are going to ask you how you did that.
Yeah. Dr. Heit, you're brilliant. Speaking of leadership, you're at the helm of this. Thank you so much for all the time, energy, heart, and soul that you are putting into bringing these pieces of the puzzle together and the collaboration that you're creating in this industry. You are the change that we need to see in our world. And I look forward to working with you next week in Las Vegas. To all of you joining us tonight from around the world, thank you so much. We'll see you next week live from Las Vegas. Thank you.